Happy Tuesday, everyone. My name is Annalisa McKee Chow. I am a Director of Domestic Violence Services and Shelter Operations with SBCS. I am also your acting president of the San Diego Domestic Violence Council and very excited to have you all today and to welcome our presenter. We have Jessica Mueller, PsyD. She's a licensed clinical psychologist in California. She graduated with a doctorate in clinical forensic psychology in 2017, and she is currently the director of forensic training at the Institute on Violence, Abuse, and Trauma, which is also known as IVAT. She is the co-editor-in-chief for the Journal of Aggression, Maltreatment, and Trauma. Dr. Mueller has experience working in California and New Zealand correctional settings from 2015 to 2025 in various roles, including as a clinical psychologist and principal advisor on mental health and addictions. Clinically, Dr. Mueller is trained in a variety of therapeutic techniques and continues to see clients. Dr. Mueller taught at San Diego State University in the Forensic Psychology Certificate Program from 2018 to 2024, and she maintains a research lab at SDSU, supporting and mentoring students in research methods. She has been an adjunct professor at Alliant University since August of 2025. So quite the experience you're bringing to the table today to share with us, and I'm so looking forward to this topic. So thank you, Jessica. Go ahead and take it away.
Oh, thank you. Hi, everyone. I'm Dr. Jessica Mueller. Thank you for the warm introduction. I'm going to be talking about the research on the effectiveness of better intervention programs today. If you're able to, and it's safe for you to, if you could drop in the chat, like if you are running better intervention groups, um, overseeing them, anything like that. I think that would be really helpful and perhaps guide discussion. So, just kind of some overall objectives. I know this was on the flyer, but this is kind of what we're going to be covering. Again, the empirical literature on the effectiveness of BIP programs, outcomes, male versus females, looking at factors that influence program success and things like motivation, program completion, risk level, and looking at some future directions on how we can improve these intervention programs and reduce intimate partner violence. Uh, so just to give some introduction and research context, um, I don't see anybody in the chat responding if they do anything with better intervention programs. So if for those of you who are not familiar with them at all, sometimes overseeing and sometimes facilitating, okay. Um, Better intervention programs are structured programs designed for individuals who commit intimate partner violence. So typically these are court mandated, but they can be voluntary. Those who are voluntary are less likely to drop out. Um, and they usually have higher engagement rates compared to those who are court mandated. Um, I personally do not like the term batterer, but that's in the literature. That's kind of what these programs are called as better intervention programs. But they are meant to focus on taking accountability for the behavior, changing behaviors, beliefs, and attitudes around use of violence, and reducing recidivism. So ideally, they're teaching nonviolent relationship skills. They're addressing core beliefs that are relevant to why they're engaging in abuse. They are um, looking at promoting like that responsibility and accountability piece. Oh, I've got an APS investigator. I manage the Better Intervention Program at Palomar. I refer to group treatment, work with victims. Okay, cool. So she's kind of got a little bit of a mix. So there is a recent article published by Franchino, Olson, and Chesworth in 2024, and basically they had looked at how 46 of the US state standards that govern intervention and better intervention programs And they were considering whether those standards reflect what is considered in the research best practice. And they found that most state standards have changed very little over the last decade and often don't align with current evidence and research. Most programs are still using the Duluth model, which I will talk a little bit more about later. But there's not a lot of wiggle room as to what allows states to kind of choose programs, and states don't often allow people to kind of deviate from what is in those state statutes. So, for example, if a state says you need to use the Duluth program to be accredited and recognized, like that's what you have to use, and there's not a lot of wiggle room around that. Um, Most states didn't cite or provide evidence for how they developed the standards that they use. They were like, this is what we're saying we're doing, so this is what we're doing. There was not a lot of option for things like individual treatment. Most state standards and statutes recommend or mandate group treatment. So, uh, yeah, not a lot of opportunity for something that's more individualized. They don't require things like program evaluation, and this can obviously be a limitation. I earlier today I was looking at Texas because they actually did a very comprehensive like program evaluation of their batterer intervention programs. But it was really interesting because they are using mostly Duluth, but some kind of mix of things. And some of the other more promising programs were not something that they are currently using or considering. So we'll talk a little bit more about that as well. So, those of you who are at all familiar with this literature, the research findings are contradictory around whether or not batter interventions are effective. Some studies show that there is a reduced risk of arrest. So, for example, that Texas study that I just mentioned, they did show a decrease in rearrests. But there's still contradictory information regarding like whether it actually reduces things like assaults, if it actually improves partner safety, if it improves things like family functioning, and others find very little or no measurable effect across any of these domains. So there's a lot of reasons for that. So yay, more things to discuss today. So the Duluth model comes out of Minnesota. And I know I've already kind of mentioned it, but this is one of the kind of, I guess, earlier batter intervention programs, and it focused a lot on like feminist theories and power and control dynamics. And so a lot of states still use this, despite the contradictory evidence, because that's what a lot of the research and data is based on, is how effective the Duluth model specifically is. So, literature often compares the initial kind of Duluth model to things like CBT or psychodynamic groups, purely like psychoeducational or skill groups, hybrid models. But a lot of programs, even though state statutes tell you that you should be adhering to like a very strict, rigid model, most kind of blend some of these approaches, making like model level, like is Duluth specifically or is CBT specifically, are those approaches themselves considered effective? The and this comes from Better Women's Justice Project. So that's kind of something important to consider is like do we want to understand like are specific models like individually beneficial, or is it more about like the facilitator's presence, things like that? And another consideration is how we kind of operationalize or define like what makes a program effective. So a lot of folks will say things like rearrest. Like that's what a lot of how we determine like what does it work? Is it effective? It's like, did we show a reduction in rearrests? But we're often not considering things like, um, did it impact or support like a better family functioning? Did it address like social determinants or like support people and like the social aspects of either like getting them back on their feet if they had just been arrested or like more trauma informed approaches. So how we kind of define that is important. So most of my experience has been working with women. And so one of the reasons I'm talking about this today is because when I was working with women in a prison in New Zealand, and I saw this in California as well, is they were asking about like a women specific intimate partner violence program. And I had dug up a whole bunch of research, and there's obviously not a lot of evidence-based practice specifically for women. And so we were looking at trialing a model specifically for our female, the females in our care, particularly because the officers were selling them together and there was like an increase in violence and the officers that I was working with were having a hard time kind of managing these dynamics. So that's one of the reasons why I got kind of interested in this area and then kind of delving deeper into it. I'm like, oh yeah, we're like not doing great in terms of research with female IPV perpetrators. So, again, if those familiar with the literature, there is a substantial gap between what we know about males and what we know about females. Um, what we do know is that both populations have a high complex trauma history as a central feature. And interestingly, in heterosexual relationships, women actually had higher perpetration rates compared to men, but we know that males are have more lethality and more like serious risk for injury. But given the high prevalence, you would think that we would have more data and research for women, but we do not. So, some of the other kind of key contributing factors for domestic violence, victimization, broadly speaking, is high rates of adverse childhood experiences, exposure to adult victimization and or re-victimization, uh, mental health diagnoses, things like PTSD and depression. I had worked with several females who had significant trauma histories who went on to engage in intimate partner violence, although theirs was a bit more kind of retaliatory, and we'll talk more about that in a second. Other factors often not addressed in the research or excuse me, in programs is substance use disorders and how that is used to kind of address underlying mental health conditions or coping with trauma. And there's also a lack of standard screening and assessment tools that are used to help target interventions and placement in group. So I was actually talking with somebody local in San Diego yesterday, and they were talking about how they do have a standard screening tool that they use across their workplace. And it has language that helps classify people as low, medium or moderate or high risk for reoffending. And so that was kind of how they kind of classify and place people in groups. And there's nothing to say that that's wrong, but like across the field, we don't have anything that kind of helps support that. So, I mentioned adverse childhood experiences as a pathway to perpetration. I'm sure many of you are familiar with the adverse childhood experiences study done by Folletti and colleagues in 1998 and the subsequent research that's followed. Um, you can see on the slide we've got the categories: abuse, neglect, and household dysfunction, and how that's kind of categorized. But what we know is that each individual adverse childhood experience increases the odds of intimate partner victimization, or sorry, perpetration by 15 to 20%. And I was looking at some statistics preparing for this, and those who are incarcerated have at least, the statistics show at least one adverse childhood experience. 98% had at least one adverse childhood experience, compared to the general population, which has about 60 to 67% have at least one ACE. What research also shows is that women with four or more ACEs are significantly more likely to engage in IPV and have co-occurring PTSD, depression, and substance use. Exposure to domestic violence is one of the strongest predictors for adult perpetration for male offenders. But trauma-informed treatment addressing adverse childhood experiences can show greater reduction in recidivism compared to standard Batterer intervention programs because few meaningfully address adverse childhood experiences. Other areas like racism, economic inequality, structural violence, and social determinants that lead to later IPV perpetration. So I know we were talking about, how do we balance like state standards as this is what we need to do for um, what the state asks us, whether whichever it's the Duluth or the stop model, whichever model they want us to use, but how do we make it trauma informed and address the risks that we know to be contributing, things like adult or childhood trauma. Some other kind of treatment considerations I mentioned before that it's often mandated to be in a group format, and there is some things to consider around this because group treatment may not address individual needs like risk level, like personality characteristics or trauma history, or might not have cultural components. It might not necessarily address substance use. It might not necessarily address the different types of offending or in reasons for offending. But research has shown that addressing these can significantly improve outcomes. There's a lot of data specifically around substance use that shows addressing this can help reduce later reoffending. So I mentioned typologies. I don't love kind of how we classify people, and like I don't like putting them kind of in a box. And I often, when I've talked about typologies previously, you people might have heard me say that, but I think, and if you're looking at IPV related programs and like in treatment, having an understanding of like where a person falls in terms of these typologies can be helpful. And these come from Dr. Johnson, I think in 2008. Understanding like, is the person a primary aggressor? And by that I mean like, are they initiating or harming someone unprovoked that is specifically towards their partner, without a history of like being victimized by that partner? Are they more retaliatory? Are they or reactive? So are they someone who's been in a long-standing relationship with controlling abusive behavior towards them and then they respond violently? Um, it might not specifically be immediate self-defense for some. I've worked with some women who later harmed or killed their partners because they had the opportunity, I guess you would say, because they knew that if they didn't, then they would further be harmed. And so it wasn't like violence wasn't something that was inherent to them, and they wouldn't have considered themselves the primary aggressor in the relationship, but they responded with violence. Things like bidirectional violence, where both partners engage in physical and emotional violence towards one another, and that can be mutual. And you can see maybe why I don't love these typologies because it could be difficult to kind of parse out where a person falls. But even with considering some of these, it could be helpful in figuring out like what interventions might be helpful, like where to place them in a group, things like that. The last one is around self-defense, and so acting as direct self-defense as defined by legal statutes, and so responding to immediate threats of safety. Um, there's some cases where um, myself and my colleagues have worked on that. There there is self-defense related factors following like immediate threats to safety, but the justice system does not care. And but again, I think having kind of a broad like overview of kind of these different types of female offenders can kind of help you decide like what interventions and treatments might be most helpful for them. Um, So Holdsworth Monroe and Stewart came up with typologies for male IPV offenders. They came up with these subtypes and they determined about like 50% were family only offenders. So they considered about uh, about 50% were these family only offenders, and they had what they considered less severe violence, low psychopathology, violence generally limited to only the family again. They're most likely to respond to treatment, and it's often that they had high marital stress and poor conflict resolution skills. I have seen some domestic violence offenders, and I'm sure many of you have, that I would consider they were probably engaging in family only related violence, but it was quite severe. Um, and they may not necessarily have had like significant psychopathology or mental health issues, but their threat to their partner was quite severe. So I don't 100% agree with this, but again, classification can be helpful to some. In the middle, we have the dysphoric slash borderline subtype, which they consider like the more moderate severe violence, includes things like significant emotional regulation, having violence outside of the family, fear of abandonment may be really common. Trauma history is very common. Higher rates of like depression and borderline traits. So they estimated that about 25% of those in the program had this subtype. And then the last is like just the generally violent antisocial group, which is about 25%. And they determined that those are generally the most severe and have more frequent violence because the violence extends beyond their partner. They're least responsive to standard treatment. They may or may not have a criminal history, significant substance use, and antisocial personality features. And so, again, something that may be helpful may not be helpful, but something to possibly consider and with groups. Kind of sticking on the male offenders, I mentioned before that a majority of research does focus on men. Um, there is some general research that shows some reduction in physical violence. Um, there's less of an impact on the emotional psychological abuse. But there is actually not tons of research on that area. And I mentioned speaking to somebody yesterday specifically about this around how can we better target the like emotional physical abuse. And my question was, well, how can we measure it? Because if we're relying on self-report of the person in the program, we may not be necessarily capturing that reduction of emotional psychological abuse. Some of the challenges might be like resistance to accountability or minimizing behavior. They may, and I mentioned this before, around lower motivation of being court ordered. If there's heavy reliance on how we look at like the rearrest, reconviction to define progress rather than focusing on like, did we make this person like a better family, safer family member? Some research looking at male offenders, about 30 to 40% meet criteria for a personality disorder. About 77% reported witnessing domestic violence in childhood, which was really high. Um, but male offenders had 2 to 3 times higher substance rates in male IPV perpetrators than the general population, which again is quite high. And I already mentioned about the antisocial group on the previous slide. They generally have the highest recidivism risk. Some other kind of key points around male offenders, something that is often not necessarily addressed the in the literature or in not in the literature, sorry, there's someone like weed whacking or mowing the lawn right outside my window. I don't know, I hope you guys can't hear it, but it's distracting to me. Um, male what's often not addressed in better intervention programs is things like attachment styles. So, what does it mean to have insecure attachment? Are they fearful, preoccupied? We know that there is there is a strong predictive portion of that for IPV perpetration. Things like fear of abandonment being linked to controlling behaviors. And so we know that we've known for a long time now. 2005 seems like yesterday, but it was 20 plus years ago now. But programs are often not addressing those attachment styles. Power and control dynamics are one of the central features in the Duluth model. The power and control wheel is one of the things that I actually like about the Duluth model because I do think that that kind of helps define coercive control and makes the points really clear around like using intimidation, isolation, jealousy, things like that alongside physical violence. So that is that those are often considered, that's considered in the Duluth model. But coercive control and other like emotional abuse pieces are sometimes missing from models that are used. I mentioned before things like childhood maltreatment and trauma exposure. Um, Often are missing. And having worked with males and have done male group therapy, a lot of them wouldn't want to talk about their childhood trauma in a group setting with other males. And so this could be a challenge to address in a group setting. They may not want to talk about like their upbringing and like what they witnessed as a kid. Um, And other considerations in the research, things like traumatic brain injuries, frontal lobe dysregulation, impaired emotional regulations through, I don't know, things like ADHD or like fetal alcohol syndrome, which are both have high rates of prevalency in our justice system, are often not considered in our better intervention programs either. So to kind of get into the treatments themselves, There are 12 that I'm going to present, and they're not in any particular order. But the first one is a female only program that's called Weaver. And it was developed, I want to say, in the late 90s, looking at specifically ending abusive and violent episodes of women, looking at parenting related issues, child abuse co-occurrence, self-esteem, cultural issues, addressing things like PMS, hormone fluctuations, things like that. And there's an alcohol and drug component to that as well. There was some early promising research on that, and was developed by the president of IBAT and two of his colleagues. But I haven't seen newer research or like continued use of this, even though I actually like how it's laid out. Um, the STOP program, many of you might be familiar with this because it's one of the common programs used by larger groups. I know the military, I think, uses the STOP program. Um, the STOP program was created by David Wexler. I think I have one of his manuals behind me. This does address attachment issues, CBT based. It addresses some ACEs, things like that. In on the women's side, there is more like trauma, attachment theory, more mindfulness, like women's own healing journey, recognizing like women who use force for control. So they do have a men's manual and a female manual, um, which can be quite nice. But I haven't reached out to Dr. Wexler recently, but when I last did, he wasn't aware of any outcomes specifically around the effectiveness of the women's program. Um, and I haven't seen as much research on the men's for the STOP program, but I didn't actually ask him. I was more looking at the females. But the Duluth model, I spoke a little bit about. It does have the power and control wheel. It's like very psychoeducationally group based. It's one of the most widely used programs globally, but it is often critiqued for the lack of trauma focus. And research recommends like combining it with things like CBT components. There is the model's primarily male. Their website notes that they have a female program, but I also couldn't find any research looking at the effectiveness of the program or like what the components are. So I'm not sure if anyone uses the female Duluth model, but I would be interested to hear how it works. There's cognitive behavioral batterer intervention programs. I've seen a lot of them are mostly male based. I've seen a few female ones. Research shows that the evidence is stronger than using just the Duluth model alone. With the CBT based models, there's usually some motivational interviewing that gets integrated to kind of keep a person motivated and hopefully not dropping out of the program. There's a communication skills component, but it is focusing on cognitive restructuring of the attitudes, beliefs, and behaviors. Um, the CBT-based better intervention programs do have kind of an anger management, emotional regulation component. I know working in the work that I'm currently doing, I've seen judges order anger management for domestic violence instead of a batter intervention program, and that's something that we, as a team here, recommend against because anger management and batter intervention programs are very different, and like the length and quality of those programs are very different. So, okay, the next set is the Trauma-Informed Abusive Partner Intervention Program. This is explicitly addressing participants' trauma histories. It's teaching emotional regulation skills, focusing on like why reactions happen and not just stopping them. Um, this makes sense, right? I have young kids, and if I just told them to stop doing things, they're going to ask me why 19,000 times in the process. So, like, understanding why the function of the behavior as they happen, not just like, hey, stop it. Um, those who went through this program, they were less likely to be arrested compared to the control group, but there were still continued problematic views of gender and roles that persisted even after completion of the program. So I thought that was interesting. Um, Another way to change, another way choosing to change is um, that is the work of Nada York. Some of her work is being used. I know it's being used in Northern California, but it's very like victim centered. It follows a risk needs responsivity model. Dr. York was a former probation officer, so she had really used a lot of her experience to help kind of design this program. It's for adult learning. It is trauma informed, and it is, she markets it as something for all adults. So it's one of the few that can be used for like um, folks who are in like LGBTQ relationships or for those who are transgender. Um, the domestic violence or domestic abuse intervention program, similar to the Duluth model, so I won't go into too much about that. The Vista shift, positive shift model comes out of the US and Australia. It is really interesting because it's one of the few female programs, and they actually did a study, I think, in one of the Australian prisons, and they found that overall it reduced anger and nervousness and some of the target behaviors they were looking at, but it actually increased depression in many of the participants. And their N, I believe, was only like 6. So, really small sample, but at least there's some data. So, that's promising. It seems like they're doing really good and interesting work. So, I'm excited to see like, where that goes. But there is a need for larger studies, obviously. Um, there are emotionally intelligent batterer intervention programs. These focus specifically on like emotional intelligence, emotional awareness, self-awareness, shame and trauma, and they it uses more of like the cognitive restructuring, mindfulness techniques. Um, the achieving change through values-based behavior is a kind of a newer idea program for batterer intervention programs. So the results it's essentially acceptance and commitment therapy based. And the results are really promising in terms of like looking at reducing specifically the number of charges a person has or reducing recidivism. But it focuses on um, noticing like thoughts, emotions, urges, like bodily cues without acting on them, reducing experiential avoidance, defensiveness, the rigid kind of self-justifying narratives like the self-blame, um, or not self-blame, the other blame. Um, a big part of that is like clarifying values and are you acting in accordance with your values? It also includes a lot of the ACT therapy components like thought diffusion, radical acceptance, um, values, and some of the behavior skills. Um, Mentalization-based therapy, and I'm not sure how familiar people are with this. It comes out of the UK. It's Fonagy and Bateman. And there's not a lot of evidence supporting it yet, but I think it's something that we're going to see more of in the future because it's specifically looking at and for personality disordered folks. So the research is really good for those with like things like narcissistic personality disorder, borderline personality disorder, and antisocial personality disorder. And so in my mind, I think it's promising and could be used um, with better intervention programs. But one of the components is shifting from like, what did she make you do to like, what did you imagine was happening in your mind and how certain were you? And like getting the person to consider the perspective of others in a more meaningful and different way than we might have previously. It can target things like hostile attribution, entitlement, things like jealousy, rejection sensitivity, coercive control, um, using like here and now exercises. Um, there's like a key part about like the shame and rage cycle. And that has a responsibility piece around like taking responsibility without making excuses. So, again, not something we see a lot of evidence for yet, but I think could be really promising. Um, so in terms of male perpetrated treatment outcomes, as I mentioned, the evidence is mixed. So there's two key randomized control trials that reached completely opposite conclusions. One looked at a sample of 42 men comparing individual CBT with motivational interviewing to group CBT and better interventions. And they found that group treatment provided equivalent or greater benefit compared to individual therapy. In that study by Murphy and colleagues, he and his group, they actually did consider like the victim partner um, in the feedback, and they reported that they favored group treatment with significant differences in psychological aggression and medium to large effect sizes for things like physical assault, emotional abuse, and partner relationship adjustment. Um, they felt that this was due to the positive, like mutual support influence of the group setting. Um, but again, this was 42 is generally a pretty small sample, so something to consider. Another another group of researchers, Dr. Stover, who I actually met last year at a conference, they did a randomized control trial of 82 fathers, and they were looking at an individual intervention, which they call Fathers to Change, which has a lot of like parenting components. Um, and they compared it to the individual Duluth and it was Fathers to Change individual Duluth and group Duluth. And they found that individual treatment showed the higher session attendance, stronger therapeutic alliance, greater self-report and reduction of IPV compared to group treatment. And of the three, the Fathers for Change individual intervention was shown to was the only one that showed improvement in emotional regulation. And they were doing some really interesting work, but they are only looking at male offenders for their work. There was a meta-analysis done of 14 studies with untreated comparison groups, and they found that individuals who were in the Batterer intervention groups were approximately 3 times less likely to have DV recidivism and 2.5 times less likely to have general offense recidivism. And they used criminal justice records specifically for this. However, this wasn't significant when they were looking at like survivor reports, because again, like that's often not included in treatment. So the I guess like the overall kind of takeaway around like male perpetrator treatment is that there is like some modest, like inconsistent average benefit, but because of things like substantial dropout, like short term, we could probably say that programs are beneficial. Um, Medium term, like 1 to 2 years, like benefits may persist, but it can be somewhat attenuated. After 2 years, evidence is pretty uncertain. Most only follow up after a year or 18 months. It's not necessarily negative, we just don't know that much about it. Within group improvement, so uh, with it, groups compared to the control groups, those who got the intervention versus the control group, it's encouraging, but there's still weaker evidence related to this. And the control group evidence can still be mixed, and we should still be cautious about how we're talking about the effectiveness. So overall, again, it's still unclear what is and isn't working for some. And again, I think that depends on like how we're measuring outcomes. So thinking and looking at female perpetrators, so I mentioned the Vista positive shift model. They had an N of 6. But there's currently so little um, research on what works for females who are involved in these programs. We don't know if female batterer intervention programs are effective in reducing recidivism or partner violence. Um, a lot more research is needed on things like program outcomes, specifically for those in the community, but also for those who are incarcerated. We know incarcerated women have high trauma, mental health, and substance use. But again, the data is so sparse and relies heavily on things like pilot studies, older descriptive reviews, and evidence that's essentially been extrapolated from the male perpetrator intervention research. So thinking about programs that have like a male-female model, then they may be different. They're still relying on a lot of the research saying, well, our male model works, like come use our female model. We don't know anything about it. So, in terms of research gaps, I've highlighted a lot of them, but I guess to kind of summarize, the lack of research on effectiveness and efficacy of IPV programs, specifically designed for justice-involved women. There is a lot of work to be done on looking at outcomes for women. Uh, in terms of male program efficacy, meta-analyses show modest effect sizes. So about again, as I mentioned, it's very mixed. So recidivism rates vary between 10 and 64% across methodologies. And so it's really hard to determine like how effective a program or a specific model is given that. There is very limited research on IPV within same-sex relationships or involving transgender individuals. There are current programs often lack inclusive, identity affirming, and culturally responsive programming. Thank you. Um, there is a lack of this information, and how it similar with the justice involved females. There's just such a limited research base on like addressing those individuals. I mentioned before, like why I got interested in kind of this area was the cohabitating in custody and selling couples together. They were like, "Ugh," the officers are like, it's just easier for us. And I'm like, yeah, but the risk of violence is really high because you don't know what's happening at night in the cell or behind the door that's closed unless others are telling you and they're not going to tell you. So it significantly increases the risk of continued violence and can undermine treatment goals. So I was working with a woman who was in a relationship with someone who they were celled together, and like their relationships, their relationship continued to be a significant barrier in our ability to like actually work through the issues because it'd be like, I'm told I'm not allowed to see you. If I come out and see you, I'm going to get in trouble. I'm going to get assaulted. I can't talk to you about the following things today if I do come see you. And so it made it really challenging. And there's not much research on that either. Um, I've already mentioned there's a lack of randomized control trials looking at IPV offenders. And because of that, there's a lot of limitations to how we decide what programs are beneficial. And it limits our generalizability. And I mentioned before around like the growing evidence between things like those with the TBI, folks with ADHD, other kind of neurological impairments, and the connection to IPV. Um, in both genders or sexes, there's not a lot of, I haven't seen programs that are kind of addressing those. They might use like some more simple language, but generally speaking, they may not necessarily be getting like the specific individual needs met around their neurodiversity or neurological impairment that would be like an underlying or root cause for or one factor causing or contributing to the IPV. Okay. So, having worked with IPV, both perpetrators and survivors, my kind of trauma-informed practice recommendations are recognizing the how their trauma history is showing up in their behavior, their relationship patterns, and their emotions. Promoting safety, trying to create a physical, emotional, safe space, whether that is again with like victims or perpetrators. Um, Cultural humility. I don't think I mentioned this on the other slide, but there's not a lot of like culturally specific or culturally responsive practices. Um, and things like gender roles, or cultural norms around violence, like may not necessarily be addressed. And as one of the programs I mentioned, they didn't really consider those the impact of gender after the treatment program ended, there was still concerns around like gender roles and norms and things like that. So how we address that is important individually or in a group. Um, Autonomy and choice. I mean, this obviously you need to be a little bit careful with around coercive control, but supporting a client's sense of choice, control, and self-determination um, can be really helpful. Sharing power, this can directly, hopefully, counter IPV patterns. Having integrated care, and so I mentioned like group treatment is usually what is recommended across the states, but having like individual therapy or like substance use treatment, things happening simultaneously rather than isolation can maximize effectiveness. And we know that from research. Um, and I know that I've kind of been like a little bit negative about group treatment, and I don't mean to be, but we do know that like th healing can happen in relationships, and therapeutic relationship itself can be healing, and the modeling in group and individual treatment can go a really long way with people and like how they just learn to connect and like be with others. And we talk about like recovery is possible, and most IPV offenders can change with appropriate sustained intervention. So I always like to talk about like there is hope and consideration. And I'm sure a lot of you are doing amazing work in that space. In terms of treatment and assessment considerations, I mentioned when talking about the typologies, considering like who is the dominant aggressor in the relationship. Is there past victimization? Is there prior abuse or traumatization? Is there strangulation history in the relationship? Is there repression history? Like a lot of the things that I've got kind of on the slide, these are important questions because they may or may not need to be targets for addressing like individual needs. Um, some of these things may or may not be addressed in group. And so, like, how do we make sure they're getting like any kind of adjunct care that they need? Things like how are they emotionally expressing themselves and like how are they how do they regulate? Um, what are their typical conflict management styles and like learned patterns? Again, some of the factors that I've kind of already talked about around neurodevelopment history and substance use and attachment style, but readiness to change and stage of readiness and like how do we get you to keep showing up? Um, yeah, what social support systems, what factors do those play? But understanding like how they can play a role in treatment is important, but also like assessing for these things so that you know like what it is the person might need. So just some broad stroke kind of future directions and recommendations. Um, so a meta-analysis of interventions for IPV perpetrators did find that the programs that incorporated substance use and trauma components performed better than those that did not have them. Um, I think that that is incredibly important to consider. Perpetrator treatment literature repeatedly talks about like a one size fits all approach for Batterer interventions can be limited, and things like trauma history, mental health, and substance use are important treatment needs that should be addressed. Building motivation and reducing dropout early on is a key component in keeping people in the program and seeing like continued success. So, those of you who do some better intervention work, I'm not sure if you have lots of dropouts, but it's not uncommon. But using motivational interviewing and motivational enhancement strategies to get them hooked in, especially for those who have low readiness for change or who very quickly project blame, getting them to be involved using some of these strategies can be really important. Integrating survivor safety and coordinated community response and program design. As I mentioned, there's often not a lot of consideration for like the survivor's voice in treatment. Like, what are they seeing? If anything, if there's allowed to be contact. But I know I know someone client working with that is going through domestic violence better intervention program, and they're going not because they've perpetrated abuse towards a parent and a child, but they're not getting any feedback like from how it's working with either of the survivor. And there's continued contact there. And so you think that that would actually be really important information to have. Um, so perpetrator shouldn't, or sorry, programs should not evaluate perpetrator change in isolation. They need linked survivor support, safety planning, and coordination with health advocacy, probation, and child and family systems. Um, I don't know the full scope of what all of you do, but I know that there are a lot of systems that are really siloed, and I know how frustrating that could be trying to navigate and work through that. And so, like, having bridges where we can work together would, again, go a long way. And I mentioned the limited research around same-sex relationships, a lack of like inclusive, responsive programming, and it, an area that I didn't talk much about is around there's a few programs that are incorporating restorative justice or transformative justice practices. So looking at like how to repair the connection or kind of re repair or like think about the relationship differently um, through like face-to-face meetings or like broader like kind of like focus group, different strategies for sort of transformative justice, but these approaches are increasingly discussed as alternatives or complements to existing Batterer intervention programs. But depending on the model and like how it's used and whether there's like um, the perpetrator and the survivor being like in the same room, like a lot of preparation and thought really needs to go behind that. And so it's not something, obviously, we talked a lot about today, but it is something that is being considered in um, these approaches and programs. So just some key conclusions to wrap up that, trauma is a large component for both males and female offenders. That having things like not just gender responsive, but cultural responsive, gender affirming approaches, like those can go a really long way. And we don't have a lot of evidence supporting that. I mentioned around like typology, how that could be helpful in terms of like matching intervention based on, the subtype or where a person kind of fits. and again, help target that intervention. And having more integrated, holistic, less siloed care can has been shown to be more effective than just single focused interventions. And we need to continue to do a whole bunch of research and appreciating that we're in a space that where funding is very limited. And I asked somebody yesterday, I'm like, if you have data, I'll run it. Like, please let me run it. We need more data. And I extend that offer to you guys too. If you have data, I will help you run it. I teach research methods and stats. So, um, but we do need to expand our research and knowledge in this area because um, as I've said many times, it's research is very mixed, and particularly with females, like we have such little evidence of what is and isn't working. So, that is what I have for you guys. I'm happy to answer questions. I've got my contact details on the screen as well if you're too shy to ask in front of anybody, but it's been a pleasure, but if you've got questions, you can either, I think you guys are meant to put your questions in the chat. So,
Yes, and I'm not seeing any questions yet. Give it a minute.
ooh, Andrew has a question.
Mm. Yes. Hi,
Oh,
Jessica. Um,
Hi.
so the acceptance and commitment therapy
Mhm.
adjunct to these BIP programs, are you familiar with some of the work in 2022? I think it's Zeilinger. Starts with a Z. I think, but basically they were looking at ACT and they saw some statistical improvements with,
Hmm.
adding that to these programs. I'm curious about what research were you looking at?
Oh, well, if people are welcome to my slides, but I have all of my references in my slides. And I've got three I need to get rid of my chat. Specifically looking at the ACT stuff. Let me see. Let's see. I can tell you because it is in my. It's in the notes that I did not use. Do. Searching my notes and my computer is going so slow. Um,
just while you search, Dr. Miller, there's a question from Emily McKay if there will be access to this recorded meeting later. We do put them on the DV Council YouTube. So yes, there should be the recording uploaded, probably within the week.
Cool. We'll have access to the slides as well.
Dr. Mueller, will you be providing us the slides?
yeah, I'm happy to email you my slides.
Okay, thank you. Yes, we'll send those out.
Cool.
Um,
Any other questions from the group?
see.
Just people sending thank yous. Thank you. Great information. Thank you so much, Jessica. This was great. One, I'm interested in how you see the relative impact of the program or program structure and model compared with the relationship, accountability, or influence provided by the facilitators.
I'm still looking for that reference, but it should still be in my slides, and yet I cannot find them because I have so many. I'm interested to see how you see the relative impact of the program structure, the program structure model compared with relationship accountability. I so we know from the literature that the facilitators and like our therapeutic relationship has a really strong impact on outcomes, but I haven't seen a lot of research that looks specifically at um how that directly impacts like program outcomes. Um, but I'm not sure if that answers your question. Comparison with the relationship accountability.
You're welcome to come off chat if that's helpful too.
I was just curious as to like how you saw it, given that you have done all this research and which was an amazing presentation, by the way, very informative. And there's like so many things coming together to explain, the best outcomes in your eyes. So I'm just wondering, as a facilitator, if you think maybe it is aside of also as a facilitator having like the training, right? But like, is it possible for a facilitator to kind of have pieces of these different kinds of programs to then be able to advocate for, different things, or if it's like one specific program that will be the most effective? Yeah, I just was curious about how you saw it.
Yeah, I think I I mentioned meeting Dr. Stover last year and her research and the work that they're doing around like the individual outcomes, I think is really interesting that it's showing higher rates of effectiveness compared to like more of the group and Duluth models. But I think it's going to be tricky to move away from group related treatment. I do think group treatment obviously has like a really helpful place and space because it can influence dynamics and, encourage change in others. And it's more cost effective and things like that. But I do worry about like those individual factors being missed. And you can see some of the programs are kind of addressing these pieces, but some of them are addressing them like, here's some psychoed about like what ACEs are. And it's not like, let's talk about like how your childhood experiences have influenced your um responses in, your adult relationships. And so, uh, I don't know. I think that there's some programs that are showing some really promising outcomes, and like that gives me some excitement. I didn't talk about DBT, but I think I was looking and there's not a lot of research on the effectiveness of DBT in these kind of groups, but a lot of the skills can certainly be used. And so it's going to be really interesting to see some of like the more of the third wave therapies and like how those become incorporated. But as I mentioned, then it's like, how do we know what is and isn't effective if we're not using something that's like specific and manualized? And so I think that's something that we all kind of struggle with. The article that I pulled around like the ACT therapy, it was the Zarling article. Is that the one that you mentioned?
Yes, that
Yeah.
Yeah. It seemed pretty convincing at the time, but I know it's like 2022, 2023. I don't know if you've seen anything since then.
If there is, I can that was one of them. But I'm happy to look for some others and I can add them into the PowerPoint for folks if they're like super interested in that. But I think again, I think training in things like mentalization-based treatments and like ACT, I think ACT specifically, we're already starting to get some data on, but it'd be interesting to see how we get if we get data on the some of the other types of treatment too.
All right, I know we're coming up on time, so last opportunity for any questions from participants. Doesn't look like it. Well, Dr. Mueller, thank you so much. This was very eye-opening, and I just echo all the comments in the chat that it's very interesting to hear, you know, the continued gaps that exist. I really appreciated you showing, both the female and male perpetrator side of things, and then to continue to see that there's still gaps in the LGBTQ research, well, just across the board, but especially with that population. So it sounds like there's just still so much more to be done. And this is, the offender side of things is such an important part of the conversation and in ending domestic violence. So kudos to you for shedding light on this, and thank you for being available for us. And hopefully we can continue to connect and learn any further updates that come in this field.
Yeah, of course. This was great. Thank you so much. Please feel free to reach out if you have any questions, and I can happy to share my slides.
That would be great. Thank you. All right, everyone. Thank you so much for joining us today.
Thank you, guys.
Thank you.